in our podcast, we are talking about polio eradication in Nigeria, a true African success story. And I am in conversation with Dr. Faisal Shuab, the Executive Director and CEO of Nigeria's National Primary Health Development Agency. We are talking about Nigeria eradicating a virus that used to paralyze tens of thousands of children on the African continent, the wild polio virus. Dr. Shuab, welcome to Conversations About Health in Africa. It's really great to have you.
Thank you very much. It's a pleasure to be here with you.
Wonderful. So let's start with the significance of polio eradication in Nigeria for global health. Let me take you back to 2015 when Nigeria is removed from the list of countries where polio is endemic. And the other countries on that list included Afghanistan and Pakistan, and they are still reporting cases today. Then the year after, in 2016, Nigeria had its last case of wild polio virus in Borno State. And 3 years later, in August 2019, Nigeria had not recorded a single case of the virus, which set the stage for Nigeria being certified polio-free in August 2020. As Africans, we celebrated this momentous achievement, and in a world where health security is so connected, the significance of polio eradication in Nigeria and on the African continent, of course, went beyond Nigeria and Africa. It is also important for the entire global community. What did polio eradication mean for Nigeria and for Africa and for the rest of the world, in your view?
I think it's a momentous occasion for all Africans that finally we're able to eradicate a disease that has crippled so many Nigerians, so many Africans, and has really prevented them from reaching their full potential. It must be a glorious day to be able to look into the future and know that we have really cut down on the numbers of Africans that will ever be paralyzed by this virus. So for me, when I look back, it was a great day. I believe that it's the type of achievement that probably happens once in a lifetime, and I'm really proud that we were able to do this together as Africans.
Indeed, an achievement that comes once in a lifetime, and the WHO attributed this remarkable achievement to the resilience of the Nigerian Primary Healthcare Development Agency, which you, of course, Dr. Shuab, are leading as the Executive Director and CEO. Can you tell us a little bit about how Nigeria's primary healthcare system is organized and the extent to which this structure helped Nigeria to overcome its challenges with the polio program?
Right. So the Nigerian Primary Healthcare Development Agency that I lead is a parastatal under the Federal Ministry of Health, and it has the mandate to coordinate, provide policies, and help in supervising the work that states do around primary healthcare. So all of the things around immunization, around family planning, around basic services, linking services with communities. This is what with respect to the polio eradication program, the agency led the effort over the last 20 years to make sure that we put in place innovative practices, working with our development partners and donors, and making sure that people are held accountable for the work that they do. But I think one of the most important things that we're able to do in the course of the last 10, 20 years has been making sure that the communities took ownership for the polio eradication. That is to say that ordinary community members under the leadership of local leaders, religious leaders, traditional leaders, were able to see polio eradication as something that needed to be done and could only be done by ensuring that kids under 5 got the vaccinations against the wild polio viruses. So community ownership was very, very important and instrumental to the success we eventually saw with polio eradication.
Yes, community ownership is really, you need leaders in the community taking the lead to, direct these efforts. You also mentioned partners, working with partners. So in all of that time, you were fighting polio for a long time in Nigeria. You had been working with partners before, development partners, presumably others in the private sector as well who were involved in the effort. Was there something that was different about the way you were working with partners in the final push that made the difference to help you to succeed that you hadn't been doing before?
Right. I bring it down to what we call the Emergency Operations Center. So in around 2011, 2012, it became very obvious that all of the efforts that we had put into polio eradication was not yielding the types of successes that were expected because different partners were working in silos, right? So different partners will say they have enough funding for only this aspect of polio eradication, and the teams were not working together. What we did differently since 2012 was to bring everybody together under the leadership of government. Our donors, our development partners came together in the Polio Emergency Operations Center as one team, working with one plan, with one evaluation and monitoring mechanism. So we had a war room approach where we were able to use data, technology, accountability that we were able to identify what the priorities were, and we were able to channel scarce resources into those prioritized and made sure that those activities were implemented to the letter. I believe, breaking those silos, making sure that people were working together under the leadership of government was what really turned the tide against the wild polio viruses. But with all of this, we made sure that communities bought into it and that the traditional leaders provided the leadership that was required at the community level. I think that was really the turning point in our polio eradication narrative.
Breaking the silos and bringing everybody under the leadership of government and working to the same priorities. I mean, that's fantastic. So clearly, leadership played a very important role in this. I have met President Obasanjo a few times. And during the years leading up to the final push, it was said that, his leadership would make or break Nigeria's eradication efforts. And I understand others like Aliko Dangote and Bill Gates were also involved, investing large amounts of money in the efforts with partners and community leaders, community health workers. So, what was the missing link then that allowed all of this to fall in together? Was it leadership or was it a combination of other things that you have mentioned?
I think it is a combination of multiple factors. So first off, we realized towards the end of the late 2000s that the polio eradication program was a government program. It didn't have community buy-in. This is why for most of the time between 2003 to 2008, we had a lot of non-compliance, vaccine hesitancy. We had large numbers of communities that said they did not want the oral polio vaccines because they did not feel that it was a priority. We had states actually stopping vaccinations. And with those stoppages of the vaccinations, there was an increase in the number of wild polio viruses being reported. There were also new from a programmatic point of view. So on the one hand, there was non-compliance, but on the other hand, in terms of programmatic execution, we did not find that the health workers were accountable for poor performance. There were in many communities in rural areas that were not being reached. So a lot of kids were not being vaccinated. But what now happened was we identified all of these different bottlenecks and profiled specific solutions to those bottlenecks. So in terms of the non-compliance, we brought in the traditional leaders and said, look, this is your program. You take ownership, you take leadership. They did that, and we saw a transformation in the programs in terms of not reaching the kids with the vaccines, poor programmatic efficiency, lack of resources. All of those we now also profile solutions. So we made accountability very important, right? But in order to also enhance accountability, we brought in technology. So when we started out in the early days of the polio eradication program, we will use hand-drawn maps to identify where settlements were. But with GIS technologies, we're able to actually produce GIS-based high-resolution maps that give us a clear visibility of where every settlement was. So we're able to go to every settlement, every household, to make sure that no child was left behind. And then, of course, like you mentioned, because of the support of philanthropies such as Mr. Bill Gates, Aliko Dangote, and the Global Polio Eradication Initiative, the whole program was better resourced. We had more boots on the ground. We had more qualified staff actually doing the work, providing leadership at different levels. So yes, it was a question of multiple factors that had to be brought together, but it required the leadership of government under the ambience, under the remit of the Emergency Operations Center, to make sure that not only did we have the right human resources, but we had the materials. We also had the technology to make sure that we were reaching every single child. And, you know, it was very critical that we listened also to the community members. Yes, we wanted to give oral polio vaccines to stop the white polio virus transmission. But the community members also said that we also have malaria killing our children. We also have pneumonia. What about all of those? So we listened to them. We went back, reassessed the programs, and now established what we call the health camps. So every time we went to the communities with the oral polio vaccines, we also went with treatment for malaria. We went with nutritional supplements, assessment of nutritional status. So we now went with a package of health services. So it was not only a vertical program, it now became a more integrated program, and that also enhanced the support and accessibility of community members for the white polio virus eradication program.
Lots of important points that you bring up, providing a package of care and looking at other issues that the community is facing in order to improve buy-in and bringing in accountability of leaders on the ground within the communities as well as in all of government. Very critical, and of course some parallels we can absolutely draw right with what we are living through right now with the COVID pandemic. And for instance, the issue of vaccine hesitancy. How did you convince parents and community leaders to overcome their fears of the conspiracy theories that the vaccine would sterilize children, which was of course not true, or that it would cause HIV/AIDS? How did you manage to overcome those fears within communities and convince parents to get children vaccinated?
Right, so we brought in the traditional leaders, the religious leaders, and we gave them the information that they required. So vaccine hesitancy, as you well are aware, is a global phenomenon, right? It occurs in every country, and the solutions are similar. It is about also working hard to provide the correct information. It's not enough to just work hard towards providing the vaccines, but also making sure that you are not dismissive of the concerns raised by the community members, that you are not cynical when they are skeptical. So we went back to the communities, engaged with the local leaders, provided them with the information that they needed, answered their questions in the most basic terms, also engaged with religious leaders, also showed them examples of where the different religions have spoken in favor of vaccination, and showing them very clearly that there was no conspiracy that is involved in the vaccination process. Once the community leaders, were on board, they now spoke to their people, to their followers, to their adherents, for the religious leaders, and said, look, these vaccines are safe. But beyond that, we also saw a situation where the leaders went ahead and vaccinated their children, in some instances their grandchildren. What better example, that I have confidence in these vaccines than to actually make sure that, a loved one gets the vaccines. So all of those types of interventions really helped to surmount the hesitancy. But I think one of the turning points was also when President Muhammadu Buhari came to power, and because of the large followership that he has, especially in northern Nigeria, some of the last few people that were still hesitant now saw that he vaccinated his own granddaughter, and that really, really was instrumental towards overturning the last vestiges of non-compliance in many parts of the country. So getting the local leaders, getting religious leaders, getting influential people to speak in favor of the vaccine is very, very important. And this is exactly what we're doing even with COVID-19 vaccination, making sure that people really are able to demonstrate its safety by getting the vaccines themselves and speaking in favor of the vaccine. And I believe that once as public health leaders, as scientists, we do not take the position of saying, how can people not understand that vaccines work? And instead work in the shoes of the layman, the person who is not a PhD in science, understanding where he's coming from and taking the time to explain to them what vaccination is all about. Most people are rational enough to say, yes, this makes sense. I will take the vaccine.
Yes, so engaging with people in a way that is understanding and really speaking to their fears, and of course, leading by example to show them that there's nothing to be afraid of. That's
Absolutely.
really very important, a very important lesson. What about then? You mentioned technology, and perhaps we could talk a little bit about that. During COVID, we are hearing a lot about how going forward to solve these challenges we are having with service disruptions, we need to leverage technology, and African health systems in particular will need to leapfrog some of the challenges using technology. So I would really like to hear your view. I mean, there are so many proposals that are made about how we can use technology, and some proposals, given the current state of infrastructure, just don't seem very credible, given our state of readiness. But there is value, I think, in considering what could be the low-hanging fruits, the kind of simple technologies that could be deployed in an African setting, public primary healthcare setting, as it stands today, without needing several years of investment to put it into place. Some of those things that are needed to improve service delivery in a real and meaningful way. So I'd love to hear your thoughts about what kind of simple technologies do you think could be deployed into primary healthcare infrastructure that we already have in place in its current state, the kind of low-hanging fruits that could enable countries to minimize service disruptions during this pandemic, during any pandemic situations that might come up in the future.
Right. So in any low or middle income country, in any African country, so to speak, there are the opportunities that we've learned from the polio eradication program. For example, the use of geographic information systems, the GIS. What we've been able to use this for in the primary healthcare setting is to really map out the catchment area per health facility. Using these types of high resolution maps developed using GIS technology, we're able to map out clearly which settlements fall within the catchment area of different populations, so that we know exactly who lives within that catchment area and what types of services are required. This helps for better planning. It helps you to do a better micro plan, so that you are able to really manage the scarce resources that you have for the number of people that live within that catchment area. Then you are also able to balance how do you reach these individuals in this catchment area with services. Is it a fixed post type of situation, or is it that you'll have to go to these communities with outreach services? You are better able to plan when you have a clear understanding of what is within that catchment area. But beyond that, we've also been able to use GIS technology to figure out, where we need to be able to deploy services, right? So when you have a high resolution map, you know where the populations are, but are there basic infrastructure like health facilities, like schools that need to be built, for this community? So if there's a large community of, say, 5,000 people, and maybe the nearest primary healthcare center is 10 kilometers away, then you know for certain that you really have to do something about providing outreach services from the nearest primary healthcare center. We've also been able to use our understanding of basic technology to implement telemedicine, right? So we know that in many areas right now, people in communities have access to mobile phones, right? So using those mobile phones, they're able to make calls using video technology, and ask a medical officer, a midwife, questions about what they need to do if there's an emergency, or if even if it's not an emergency, they're able to ask simple questions about what they need to do. And because of that video technology, the health worker is able to say, okay, can I see this pimple that you say you have maybe on your arm? Let me see how ripe it is. Is it painful? So you're able to carry out a consultation that probably will take a whole day's walk from the village to the health facility. But that instantaneous engagement can really take place because of the use of technology. With the COVID-19 pandemic, one thing that we've been able to do is to build capacity of health workers. So one of the challenges with accessing health services during the pandemic was that not only were people afraid of coming to the health facilities because they feel they might contract COVID-19, but even the health workers were concerned that if when they give services, they might contract the COVID-19 virus. So where we needed to build capacity rapidly, we used the technology such as Zoom, which is available freely, to actually organize meetings with frontline health workers and explain to them what the pandemic was all about, what they needed to do to protect themselves from contracting the virus. Basic things such as using personal protective equipment like face masks, making sure that they wash their hands before they attend to patients, after they attend to every patient, using gloves, using sanitizers. So we're able to rapidly reach out to these health workers because of these types of simple technology. We've also been able to go beyond training health workers using Zoom, using audiovisual technology, to also leveraging on technology to improve our ability to manage data. Like they say, necessity is the mother of invention. So with the COVID-19 vaccination rollout, what we've done in Nigeria is to look at some of the best practices in the developed countries, some parts of Africa, and then made a hybrid with what we traditionally do. So with the technology, you are able to schedule the vaccination program, get people to sign up. You categorize them by age, by profession, and then the absence or presence of comorbidities, using simple online forms. But you're also, what we're also doing is providing designated health centers where people can do a walk-in. So if you're not able to successfully actually schedule your vaccination, you can do a walk-in. So that kind of hybrid has made it possible for us to reach people faster. Again, this is simple technology that makes it easier for us to also manage the data, the vaccination data, because we're now able to categorize people into different phases. So if when you sign up to the online portal, you say you are a frontline health worker, then we know that you're a priority and we put you in phase 1. If, for example, you say you are 50 years and above, then we know you are in the second phase after the prioritized frontline health workers. Then if you say you have an underlying disease, a comorbidity, we know that you are in phase 3. And then if you don't have any of this, you don't fall into any of these first 3 categories, then we know you are in phase 4. Then in which case, we know exactly when we're going to schedule you to come in for your vaccinations. Again, this is, leveraging on very basic technology. So we've been able to learn quite a lot as a result of the pandemic, and we're confident that using our experience of rolling out campaigns, polio campaigns, measles campaigns, we've been able to learn so much about how we can reach the last mile. This is exactly the same thing that we're using to make sure that we get our vaccines out into the arms of those who are eligible for COVID-19 vaccination.
It sounds like you've really had to rethink the way you deliver primary care by leveraging technology and adopting different ways of delivering those services, relying on more of what you have. Do you think that's the future, especially in Africa, given the shortages that we have, the chronic shortages of health professionals, of nurses, of doctors? Is technology combined with the kind of workforce that we have in abundance, perhaps community health workers and nurses, the way forward, the future that will allow us to complement those shortages and enabling us to actually deliver services more effectively, even during a pandemic such as this?
I truly believe that is the way to go. That we have to use a hybrid of what is readily available and then tap into technology. And then I believe that we'll be able to front load some of the low-hanging fruits, be able to overcome some of the very basic challenges that we face with our health services. We're not going to be able to recruit the numbers of health workers that we need in our health services. But if we're able to optimize technology, then it is possible for us to expand the access that community members have to frontline health workers. And in the future, leveraging on these types of technologies will make it possible for us to shrink the waiting time between when somebody who is sick sees a health worker, and also in terms of distance, it will also make it possible for us to access care despite large distances between communities. I see that in some of the rural communities, they're tapping into the use of drones to be able to supply blood products to commodities. Again, it is with technologies such as this, low-cost technologies that will be able to help African countries actually access care. Right now, one thing that we've seen is these technologies might be expensive now, but in the next 5 to 10 years, because people now find better ways of making the components of these technologies cheaper, then it makes it easier for them to become available. So you can imagine, 10, 20 years ago, even phones were much more expensive than they are these days, right? You can get a phone for whatever budget that you have. So I believe that in the future, technology such as drones will get much cheaper, and this is the time for Africans to plug into that opportunity so that they can leapfrog, into the future with technologies and interventions that can ameliorate some of the challenges that we face currently.
Yes, and I'm sure talking to, drawing from the lessons of polio, what Nigeria has done with polio, I'm sure there are great lessons there on how, governments could be talking to the telecoms industry to make sure that the infrastructure that is needed or the cost of accessing that technology becomes accessible in order to bring services closer to where they are needed and at a cost that people can afford. And of course, we are in the middle of a pandemic, and service disruptions have been a major problem, not only in African countries, but pretty much all over around the world. But in Africa in particular, I'd like to maybe just have your comments about, what you think has been the impact of service disruptions on healthcare service delivery, because there are many projections that estimate the number of potential lives lost from service disruptions being, far in excess of the number of people who have died as a direct cause of the coronavirus, because our systems are not resilient. So what, in your assessment of how Nigeria's primary healthcare has coped during the pandemic, how, to what extent have you been able to continue providing healthcare services at the primary care level to minimize the impact of COVID-related disruptions?
So at the beginning of the pandemic, just like everywhere else in Africa, we experienced a downturn in the services at the primary healthcare level due to multiple reasons. One, there was the issue around people being afraid to go to health facilities because they feared that they will contract the virus. Health workers too being a little bit reticent in terms of attending to patients, but there was also the lockdowns. So the lockdowns also made access to transportation logistics different, so difficult. So either the health workers were not able to access their workplaces, or even clients were not able to get to the health facilities. So we saw, a decline in the number of people that accessed basic health care services. But one thing that we did quite early on was to recognize transmission will get to the communities and become, a widespread community transmission of the COVID-19 virus. So what we did was to quickly roll out a manual providing guidance to primary healthcare workers. We then developed a training, and facilitators guide for this from these manuals, and trained over 220,000 primary healthcare workers within a span of about 2 weeks. So what we did was to use technology, to use Zoom technology to train at the national level, then cascaded it all the way to the LGA and then the ward level, where we were able to provide physical distancing. We were able to do some physical training. So that helped us to quickly begin to turn and reverse the decline in the number of people that were accessing services. And we saw, from when the first case of COVID-19 was reported by the end of February, we saw a decline all the way to June in terms of people accessing basic healthcare services. But as from July, because we trained quite early, we began to see an upsurge and a reversal, and then people started accessing more care. So it was very critical that we rolled out the training early on, but without a doubt, the COVID-19 pandemic actually affected access to health services. But the lesson here is that COVID-19 pandemic is a global phenomenon. And for us to begin to build back our economies, to build back the way we used to live, it is important that as a community of humans, that we make the vaccines available to every country, to every community. There's no such thing as a partial eradication of COVID-19. For us to eradicate COVID-19, for us to control this pandemic, it's important that there's equitable access to the COVID-19 vaccine. A situation where we're witnessing vaccine nationalism, protectionism, will only delay our ability to eradicate this disease, because in the end, many more people will die from non-COVID causes because of the challenges that even COVID-19 brings. I will not be quick to say that the deaths from COVID-19 are relatively lower because, of course, you know that the data in many African countries is not as accurate when it comes to morbidity and mortality factors. Clearly, the deaths are not as bad as what we've seen in Europe and the Americas. But I do recognize that a lot of Africans also died. And, you know, that really is all about how it impacts the individual. For one person who loses his father, his mother, or a loved one, that is significant, right? It's not just a question of whether 1,000 people died or not. Just that one individual makes a huge difference. But for us to be able to protect our loved ones, to protect Africans, it is important that access to vaccine is more equitable and is more widespread. A situation where, you know, many African countries are still trying to access their first doses of the vaccine does not augur well for the global march towards controlling this pandemic.
Observing what has been happening, how countries, you know, they make all the right noises about solidarity and everybody must be protected, but do completely the opposite of what is needed to make sure that everyone has access. Just, you know, watching the debacle with COVAX and, you know, the wide support it had and the discrepancy in access to the vaccine, that gap really tells you that the world is not standing together. And I suppose this is something that Africa will have to think very long and hard about, how to prevent something like this happening again in the future. But I'd like to take you back to polio and how that has informed other areas, other disease control areas. You mentioned measles programs and so forth, all of these informing your approach. But I'm thinking in particular the Ebola virus outbreak that happened in Guinea and was spreading to Liberia, Sierra Leone, and eventually reached Nigeria in Lagos and Port Harcourt, with a traveler coming from Monrovia, Liberia. And in that case, Nigeria was able again to draw from the polio experience and from the infrastructure that had been put in place for that, and mounted a very effective response that prevented Ebola from taking hold around the country. So from the time that the index case, the very first case, was detected, it took Nigeria 3 months to be declared Ebola virus free by the WHO. And I think that's a pretty rapid and effective response by any standard. So how did that experience, that experience with Ebola virus, what were the elements that you took from your experience with polio that allowed you to be able to control effectively in the way that you did?
So it was all about bringing everybody together, understanding the the challenge, understanding the really different elements of what will be required to stamp out the Ebola virus. With the polio eradication program, we understood that we needed one plan, we needed one team. So what we did was to establish the Ebola Emergency Operations Center, just like we had the Polio Emergency Operations Center. We brought all the different partners together quite early on and agreed on one plan on how we were going to confront Ebola virus disease in Nigeria. We also recognized that there was a need to bring in communities, to educate communities under the leadership of local leaders. Again, local leaders had took over the narrative and communicated very clearly what the Ebola virus disease was about. If you remember, Lenia, at the beginning of the Ebola virus disease, there was also this conspiracy to say, oh my goodness, the Americans or the Europeans had created another virus just to kill Africans, right? So overcoming those conspiracy theories was very, very important from the get-go, so that the right information was passed and the right mitigations against the virus had to be completely disseminated and acceptable to community members. We also were able to achieve that and allowed communities to take over the correct narrative. That was very, very helpful. Then we also knew from the polio eradication program that it was important to have boots on the ground, to get people who will go to the communities and educate, but beyond that, also do contact tracing. So our experience from the polio eradication program of going house to house, giving vaccines to kids under 5 helped us replicate this permeation of communities, going to the communities and doing contact tracing, asking questions. Those interpersonal communication skills that we learned during the polio eradication program, where we're able to train frontline health workers to knock on the door and ask householders in a respectful manner, do you have a child that's under 5? We're here to give the polio vaccine. All of those abilities to communicate very respectfully to community members helped us do contact tracing. So immediately we had any history of contact with an Ebola case, we had teams that rapidly went to the communities and were able to manage community members and do contact tracing. But very, very importantly as well is that as we did all of the contact tracing, we used GIS technology to really map out where the Ebola virus disease were going to and where we needed to deploy our resources. And we're very, very happy that there was a lot of leadership on the part of different community leaders, leadership on the part of our donors, our development partners, who also brought in the resources to make sure that we practically replicated the polio eradication program in our war against the Ebola virus disease.
I remember actually the participating in a clinical trial for an Ebola vaccine around that time, just seeing how much people were suffering in the hardest hit areas. That was my little contribution. And I've been wondering, actually watching what's happening with COVID right now, that imagine if we were to have a similar situation to COVID, but with something like Ebola. Do you think we would be able to get that vaccine, even though it was developed very much, with the strong participation of African communities?
I think African countries need to participate more when it comes to these clinical trials. If there were more Africans participating, I believe that some of the hesitancy that we're seeing right now would have been much less. There are questions from Africans, around, these vaccines were mostly tried in other countries, and whether at all it works well with Africans, even though a large, sample of the clinical trials also involved Africans. I mean, the Africans in the diaspora who also volunteered and were part of the clinical trials. So, of course, you can replicate and extrapolate the findings from those types of clinical trials to Africans who live within the continent, I believe that yes, it will have been possible to to get the vaccines even much faster. But also this is a lesson for a lot of African countries to try and ramp up their abilities to locally produce vaccines. Mm-hmm. And we should be thinking about the next pandemic and how prepared we are to make sure that we're not left behind in the arena of local vaccine production.
Oh, absolutely. A great point about, thinking about the future. I think not only for Africa, but actually for the rest of the world. If you think about some of the things we saw at the beginning of this pandemic, where Europe was completely shut down and so was Asia, because COVID was, at the time, they were quite inundated in those parts. You can imagine if we were to spread risk, right? Production risk around the globe and have efficient production facilities on all the continents. Then in situations like this, you could actually ensure that the world continues to get the medical products, the vaccines that they need to be able to respond to public health emergencies. I'd like to finish by just perhaps looking back at Nigeria's great success, Africa's great success, what it means for global health. So there is a general view in the global health community, in health development, that African countries have everything to learn from others, but they don't have very much that they can teach others about controlling or responding to global public health issues. It is, of course, an issue that I don't agree with personally. Because there is a lot, I'm sure, that others can learn from the experience of African countries, whether in controlling polio, like Nigeria, like in the case of Nigeria, or with Ebola, with our malaria control, tuberculosis, HIV, and AIDS. So just to wrap up, I would love to hear from you what you think the lessons the global health community could take from Nigeria's experience with polio eradication towards controlling diseases in other areas, and whether you think that has relevance only for infectious diseases like Ebola, or it can be extended to other areas, non-infectious diseases like cancer and diabetes.
I believe that as a global community, we have a lot to learn from each other. We've seen, even with the rollout of the COVID-19 vaccine in America and in parts of Europe, how the actual rollout had a lot of hiccups, right, before they finally got it right. If you see what has happened in some countries in Africa, you've seen that they've done a better job of rolling out, effortlessly. Not necessarily because the African countries are better at rolling out vaccinations, but because the African countries have more experience in campaign scenarios. So the developed countries are more used to a very structured routine immunization system where people come in when they are scheduled. So they're not used to outreaches, campaign scenarios. But a lot of African countries, have experience with a lot of campaigns, measles campaigns, meningitis campaigns, yellow fever campaigns, and of course, the polio eradication campaigns. All of those experiences have now come to bear and has made it possible for African countries to roll out their COVID-19 vaccination programs a whole lot easier. Again, because they have memories from rolling out a lot of these campaigns. And because of the polio eradication program, you also see how, a country like Nigeria was able to rapidly control Ebola virus disease. When Ebola occurred in the United States, there was some struggle in terms of making sure that it was controlled in good time. So I believe that there are a lot of opportunities for us to learn from one another when it comes to vaccine hesitancy. A lot of the vaccine hesitancy that's occurring in Africa is actually as a result of exportations from the European countries. So how are we better able to manage vaccine hesitancy while it seems to be a growing phenomenon in developed countries? It is because our systems in Africa are also dependent on local communities, local leaders, community ownership, people really projecting their decision making to their leaders, and really following what their leaders advise. This is a little bit different from what we're seeing in developed countries. Even as we speak, you can see in countries such as the United States, where the conservatives are a large proportion of the conservatives. I saw some data recently that showed as much as 30% of conservatives don't want to take the COVID-19 vaccine, and then there are other groups that say they are not going to take the COVID-19 vaccine. So how do we break into those types of anti-vaccination movements, learning from what has happened in Africa? I think that is very, very critical and something that we can learn from.
Excellent. A great place to stop. It's not always about the resources. I think what I'm hearing from you is that the institutional memory, the experience, the fact that others have done it before, there is a lot that others can take from what African countries are doing and how they've dealt with this. So it would be very interesting going forward to think about how we can also, as African countries, be able to share those experiences better with others so they can learn from us and to be confident enough to say, hey, we actually know how this works, and we could, there are lessons you can take from us. So thank you very much, Dr. Faisal Shuaib, the Executive Director and CEO of Nigeria's National Primary Healthcare Development Agency. He's been talking to me about polio eradication in Nigeria, a true African success, and some of the lessons that we can take from that experience.